You'll do great. I want to start by letting Doug talk a little bit, if that's okay with you, Doug, about the new troponin assay that we are introducing, which is sort of the impetus for why we're doing this journal club on high sensitivity troponins.
Sure. So there will be much more. There's formal in-presentation that I'll be doing. Chris Farnsworth from the lab on Tuesday at 8:40 in the morning, according to Colin. So we'll go over the specifics of the assay then and the algorithms and those kind of things. But this has been something that's been brewing for a while. High sensitivity troponins have actually been out and been used in Europe since probably the mid 20-teens, 2013, 2014, they started coming out. And some of our articles actually use data from that time period. We are finally moving towards it. We have been using a higher sensitive troponin recently, and that was really sort of the third or the fourth generation. And now we've jumped and are moving to the high sensitivity troponin at Barnes, which will be a troponin I. And some of the differences are that this is now so sensitive that where in the past, it was sort of like, right, we all memorized 0.03, right? It was like, if it's less than 0.03, that's all you can say about it. Well, now you can go down to like 4, like 0.004. And as a result, where it was, if it was elevated, it was helpful. If it was negative, it wasn't all that helpful. Now with the new assays, they're so specific and so sensitive that if you'd actually get a not detectable, not less than 0.03, but like not less than 0.004, then that's essentially a true negative. And so it's going to change how we interpret these tests, what we do with them. And there's a fair amount of data that we're going to go over some of this, that if you really have a low risk patient based on clinical gestalt and negative troponins, high sensitivity troponins that are below the level of detection, that essentially you can send people home and do nothing more. That their 30-day mortality from MACE, which is MI, STEMI, revascularization, death, is less than 1%. And so it is hopefully going to change the way we handle our chest pain patients, both ruling them in much quicker, but also ruling them out much quicker. And that's what tonight's journal club is going to look at.
Excellent. Perfect. Yeah. With any test, as you increase the sensitivity by decreasing the cutoff, you risk worsening the specificity, and something to keep in mind. And that's why a lot of places are using algorithms that rely on not just, is it positive, is it negative, but is it positive? And then is it going up? Is it going down? Rather than just yes, no. So something we'll have to keep an eye out for. So to get started, I'm going to let the interns take a little bit of a break, and we'll start with the second year paper, if that's okay. Who is presenting for the second years?
Right here, it's Miros.
Hey, Miros, welcome.
Thank you. All right, hold on 1 second. Okay, so the article that I'm going to be going over is called Low High Sensitivity Troponin Thresholds Identify Low Risk Patients with Chest Pain Unlikely to Benefit from Further Risk Stratification. And this article came out of the Canadian Journal of Cardiology, published in 2019 by Dr. Andrew Trow and some colleagues of his out of Alberta, Canada. And so just to go in a bit about kind of the objective and why they did the study, which I think was mentioned already a little bit by Dr. Trow, is that there has been evidence with using this low sensitivity or high sensitivity, excuse me, high sensitivity cardiac troponins to be able to effectively and quickly rule out acute MIs. And so they wanted to then take it one step further and look at 30-day major adverse cardiac events and see if they can see any correlation and benefit with using it for that. And so that was kind of like what the background for the study was. And so just to, let me see here. Yeah. And so just to go into the method, so this was done over like a 2-year period, 2014 to 2016. In Alberta, Canada. It was done out of just one large urban emergency department that did have PCI capability at that hospital. And it was exclusively run by emergency medicine physicians, the emergency department at least. And so kind of the patient population that they were looking at, the inclusion criteria was that the patients, they looked at patients specifically that were 25 years and older. And they had to, the way that they identified these patients was that they have this like system in which the chief complaint was included that had chest pain being cardiac or cardiac type pain. And so that's kind of how they looked at what patients that they were going to be looking at. And then one of the other factors that they looked at is that the emergency physician determined a need for a troponin to kind of rule in or rule out this cardiac type chest pain that they were having. So in terms of exclusion criteria, so the patients that they excluded from the study were what seemed like more higher risk patients or patients that already had kind of more evidence suggesting that their pain was due to cardiac. So any kind of STEMIs, any other clear ischemic changes that were seen on the EKG. If they had a diagnosis of acute coronary syndrome within the 30 days prior to like that visit that they had. If they had any kind of hemodynamic instability, and if they had renal failure that required either peritoneal or hemodialysis, or if, of course, if they had any like issues with consenting them or anything like that, they were excluded from the study. So with that as well, so kind of the way that I looked at it again was that they had a certain research assistants there at a certain amount of time during the day. They would then identify these patients, and then the emergency physicians would kind of get more of the information. And then they also, the emergency physicians had determined their level of ACS risk based off of like purely gestalt is what they said. They would either put them in the low, moderate, or high. They didn't really go much more into the gestalt or like what was included in these low, moderate, or high groups. And then they followed these patients over a 30-day period. The majority of them, they were able to follow up like with the telephone, and those that they were not, they would follow in like the medical chart and see like what had happened during that 30-day period. And so the initial number of patients that they identified prior to like the exclusion criteria was about just over 4,000. And then given like all the exclusion criteria, they ended up with 1,167 patients and that they looked at. And so the primary outcome that they were interested in was, again, mentioned before, is this 30-day prevalence or incidence of major adverse cardiac event, which included, you know, MIs, any kind of revascularization or deaths due to cardiac causes. And then some of the secondary outcomes that they looked at was specifically looking at the individual components of that, like the type of MI, type 1, type 2, things like that. And so to kind of go over the analysis of kind of the data that they compiled with this patient population, they used like sensitivity, negative predictive values, and negative likelihood ratios with 95% confidence intervals to kind of look at these different groups that they were looking at. And then they kind of split it.
Miroslav, can I chime in for a second?
Of course.
So, like I said, up until now at our site, when our troponin comes back, it's either greater than or less than 0.3 nanograms per an ml. And so with the new assays, if you translate those to full integers, then it's nanograms per liter, it would be the equivalent of 30. The new tests go down to single digits. And so in this study, they're looking at three things. They're looking at what is the range of like not detectable. And for them, anything under 3, they could not detect. That would be 0.003 in our assay currently. They said, what is the lowest level of quantification that they can reproducibly get? And that was 5, okay? And then they said, what is the current US FDA approval? And at the time it was 6. So it was actually higher than the survey. So the FDA sort of cheated a little bit. But as a result, they're looking at these protocols using all 3 cutoffs, the absolute lowest detectable number that that the assay can find, which is 3, what they call the LOQ, or the level of quantification, which is the reproducible level, which is 5, less than 5, and then the US FDA cutoff, which is less than 6. And so you're looking at all 3 of those, and they want to look at the performance of the tests at all 3 of those levels to say, are one of these better than the other? And that's important as we move forward. But the one that we really want to think about is the LOQ, the level of quantification or limit of quantification. And for this test they're using, it's 5, which is the equivalent for us of 0.005. So it's a 10-fold less than what we're currently using. We're using the equivalent of 30 as our cutoff. They're going to be using 5. Hope that makes sense.
Yes, thank you. I apologize I did not go over that, but yes, they're looking at those three levels and then making their analysis from there. Thank you, Dr. Shar. Let me see, where was I? And they're using the analysis of all of those 3 different levels of the troponin, which, like you mentioned, are much lower concentrations than we use in our emergency department currently. Okay, I just want to make sure I don't miss anything. Okay, so then going over the results of this, just over 1,000 patients that were enrolled in the study. The majority of them were male, the median age were 60, and they did have some of the usual cardiac comorbidities, the most commonly being like hypertension, hyperlipidemia, and about 20% had CAD history already. And then, so with looking at all the patients, before they broke it down between the different troponin levels, there were about 10% of the patients had a major adverse cardiac event within this 30-day. The majority of that 10% of people, or just over 10%, had that major adverse cardiac event on the index visit, or that day that they had presented with their chest pain. And then the majority of these patients were ultimately discharged, about 80%. About 20 of those % were admitted, and then it does break it down, lower percentages of the different cardiac events that they identified. There were 4 deaths in total during this 30-day period, but only one of those 4 deaths was attributed to like a cardiac cause. And then, all right, okay. And then, so kind of looking at the result, they determined, of course, that all 3 of these, at least looking at all of the information, because they also broke it down to just in general all the patients that presented, and then they also had a separate analysis of those patients that presented, and then they had the troponin level drawn after 3 hours after the onset of the chest pain. So looking at like all the patients, the sensitivity for this 30-day MACE events for the 3 different levels of the -3, the negative, or not negative, excuse me, less than 3, less than 5, and less than 6 nanograms per liter were, as can be predicted, very high sensitivity ranging from 98% with the less than 3 and to 92% with the less than 6. Also, they all had really high negative predictive values in the 90s as well. And their negative likelihood ratio was the best in the less than 3 nanograms per liter. It was 0.09. And so they were able to more confidently rule out cardiac cause or 30-day adverse cardiac event in the lowest. And then for less than 5, which is again what had been used previously, and then the FDA less than 6 were 0.14 and 0.17 respectively, which are still good, and I think significantly lower the post-test probability, so to support you ruling out major cardiac events. And so for the separate analysis they did with the patients that had presented and got the troponin after 3 hours of having the chest pain or the onset of the chest pain, you can imagine the sensitivity negative negative likelihood ratios were even better, and then it also mirrored what they saw with the other ones, that obviously less than 3 had the best negative likelihood ratios, being 0, but still good numbers and still strong numbers for being able to rule it out with the less than 6, which is the higher one. So for kind of what they discussed, their kind of focused again was that yes, this is highly sensitive, and they had an emphasis on the group that had presented 3 hours after the onset of the chest pain, and saying that all 3 of those groups, less than 3, less than 5, and even less than 6, all had negative predictive values that were very strong for this 30-day major cardiac events, and that were all fell below the 2%, that the 30-day MACE rate of less than 2%, which is what was previously used as kind of like their acceptable cutoff or threshold for this. So even the less than 3 being that, you know, not really detecting anything, it was still adequately low for the less than 6, which is what the FDA level was. And there were some, they did mention as well, 10 of the patients that had this very low level of this high sensitive troponin, and it also fit this like low risk group. Like of all of these patients kind of, in my mind, were a little kind of qualified as lower risk. They didn't have any major EKG changes. They weren't hemodynamically unstable. They didn't have a kind of renal failure, these other comorbidities. And so with this subgroup of patients that had been there at least 3 hours, had low risk, and then there were 10 patients that did have a 30-day major cardiac event that was identified. However, the physicians that were kind of making their gestalt analysis of low versus high risks, all of those 10 patients were ultimately admitted and stayed in the hospital, given that they determined that they were higher risk based off of their gestalt. So what they were saying is like, yes, this is great, and we can use this to effectively rule out low risk patients, but also take into consideration like the whole clinical picture and gestalt matters, and to not overlook that either. And what they mentioned as well as part of their conclusion is that, so the threshold that they had for this, you know, less than 2% of major cardiac events was sufficient in that it was less than their threshold, but also that level also showed that there was likely any additional testing or invasive procedures or anything like that would not benefit them and potentially put them at higher risk. So it was unnecessary. And so they determined that it was good enough for them to be able to rule out efficiently, which could help them with like throughput in the emergency department, but also not having to like obs them or make sure that they have like a very tight plan for follow-up, given that during that 30-day period, the risk was low. Let me see.
Miros, let me ask you something. Do you think that that risk, that less than 2%, that it's fair to apply that equally to all patients? So someone comes in who's 75, they've got stents, they've got crushing chest pain that started when they were mowing the lawn.
Mm-hmm.
You know, do you think that their risk with a negative troponin is the same as a young, healthy person who comes in with chest pain that started while they were having a fight with their mother or something?
Sure. No, and I think that that's the point. Like, no, I think those risks are very different. And I think that's also part of like your gestalt and the whole clinical picture is keeping that in mind on top of whatever, you know, labs that you get. And if you don't feel comfortable, then I think it's fair to keep them. So yeah, but I do think that those look very different in terms of like the stratification.
Good. And we'll talk about that more in a few minutes, but it's something to keep in mind when you see these negative predictive values. Keep in mind that doesn't take into account the pre-test risk that the patient had. And
but I think
that varies.
But I think what was important with this paper is that it was one of the earlier papers to show that even without asking all of those gestalt questions, just this biomarker test could identify a very low risk population, less than 2%. So if you add that plus your gestalt, you know, the question is that better? And I think they kind of hedge it, saying the 10 people who would have been low risk, but for whatever reason, the attending thought that they needed to get additional testing, they all turned out to have stuff. That's that combination. The other thing that was important is you sort of referred to, I think erroneously, is you said the second group was people who had been in the hospital for 3 hours. And what it was is the group of patients that when they presented and had their blood drawn, they'd had chest pain for at least 3 hours. So it had been chest pain starting 3 hours ago, so that it wasn't like, well, my chest pain started 15 minutes ago. If my first trope is negative, it's because it's just too early. And so looking at that subpopulation of people who had had chest pain at least 3 hours prior to coming to the ED and getting their blood draw, really is looking at that subpopulation who theoretically should have a positive trope if it's going to be positive. It's not so early that it's going to be like, if it was a negative, that would be a false negative because we just tested them too soon.
Too early.
Good point. All right, Miros, take us through the critical appraisal form.
Yes. So critical review form for the diagnostic. So did clinicians face diagnostic uncertainty? I would say yes, to a certain degree. I mean, I think that all these patients, there was some concern for cardiac etiology, given that this was, you know, what they were looking at. But given when they were initially presented, you have potentially an idea, but you don't exactly know what's going on. And that's why they were followed for 30 days to see if there were anything that did come up. And then they didn't mention any of those other patients that I guess were essentially ruled out, go into like what those could be, because that wasn't kind of their intent or what they were focused on. They were more concerned about ruling out than looking for exact etiology. Was there a blind comparison with an independent gold standard applied similarly to all patients? There was no blinding in this study, so that could confer some bias. And there wasn't really a reported gold standard that was used, other than if they didn't meet this lowest risk group that had already had the chest pain for at least 3 hours. And that group, they determined that they would do a one-time rule out, but everyone else they would trend, which is what we do currently. They didn't mention what the hospital's gold standard was, like if this was the high sensitivity troponin was used throughout, or if that was specific to the study. They didn't really mention that, so I'm not sure what their gold standard troponin was necessarily. And then they didn't kind of really go into any gold standards for observation or what their algorithm would be for follow-up or with either cardiology, like what that timeline looked like either. So I think that that was also, could be very variable. Did the results of the test being evaluated influence the decision to perform the gold standard? I think, yes, like given that lowest risk group, they were okay with doing just that one troponin rule out. And again, I wasn't really clear what their gold standard was that they would usually follow outside of this study. But I think it could to a certain degree affect what they were doing, and that they would be okay with just doing the single trop rule out rather than maybe a 2 or 3 to trend it. What likelihood ratios were associated with the range of possible tests? So they were all pretty good. They were, I kind of mentioned them already, going through the full analysis that had all of them, and then just compared the ones that had chest pain for at least 3 hours. Again, the less than 3 had the best negative likelihood ratios. How can I apply these results to patient care? So with will the producibility of the test result and its interpretation be satisfactory in my clinical setting? I think currently no, because we don't have it available, but I think since we're moving that way, I think that that would be something that we would potentially be able to reproduce and use in our clinical setting. And then also just being able to use it in a very kind of like subset low risk group rather than just for everyone in terms of like the single troponin rule out. Are the results applicable to the patients in my practice? That I'm not exactly sure. I'm not too familiar with Alberta, Canada. I think that the demographics could be variable, so I don't know if of these results completely would be completely applicable to the patient population that we have here. I think that I did a little bit of like demographic research into it, and there in Alberta, or Calgary specifically, where the study was, their age demographics were lower, and they had a much higher Caucasian population, and so it's not completely applicable, at least with what the information that I have. Will the results change my management strategy? I think so. I think the solid evidence that was shown here, given that this, you know, very subset of low risk group, I would feel more comfortable doing a 1 troponin rule out if it were less than 6% or less than 6 nanograms, given that the risk would still be low and the potential for harm would be higher. So I would feel more comfortable doing that, given kind of evidence that we have here, and that the you know, you'd be less likely to miss and like an ACS from this. And will patients be better off as a result of the test? And I think going back to will this change my management, I think I would be more willing and feel more comfortable with the single troponin rule out in this low risk population, given that the evidence that the 30-day MACE events were low enough, and you could potentially be doing more harm with these more invasive procedures or diagnostic tests that they would usually do. And it would help with our ED, just like throughput. If we were able to rule out more quickly, we can get patients going, and not necessarily have to wait for OBS or wait for admission to do like these stress tests, because it not necessarily be indicated. That's it, I think.
All right. Good analysis. Couple of quick things. So let me ask you this. So what was the primary outcome in this study?
The 30-day major adverse cardiac.
And what were the components of that? I know you already said this, but.
It was, so they looked at MIs, they looked at if there was any revascularization that were needed, or if there were any like cardiac deaths.
Okay, and MI is the big, so how do you diagnose MI? How do you think they determine whether someone had an MI or not? How do we usually make that determination?
I mean, with like a troponin, and if they do have like EKG changes, then you can kind of make more of that determination.
Okay. The key there is troponin is certainly a part of how we diagnose acute MI. So interesting in this study, and this often happens, that they're using the test that we're studying, troponin, to also determine whether the person had the diagnosis. So it's sort of a circular logic that you're trying to figure out how good is this troponin, but if it's elevated, you're more likely to diagnose them with one of the things in the outcome. Do you know what there's kind of bias that's called? You may not know, and that's fine.
No, I don't.
Anybody listening know what kind of bias that is when you include in your outcomes the results of the test that you're studying? So that's called incorporation bias.
Okay.
And since the test that you're studying affects whether they have the outcome or not, it can falsely increase your sensitivity and specificity.
Okay.
It's hard not to do that in something like this. I mean, if MACE is your outcome, and that's the most common thing we look at when we're doing studies involving cardiac events, MI is part of that, and you're likely going to be using the troponin, either your troponin assay or a different one, to determine whether they had an MI. So just something to keep in mind. Any other thoughts and comments?
Hey, Brian.
Yes, Evan.
So just one other thing to mention, since we're not talking about catching missed MIs, we're talking about being comfortable not doing testing. If you look at the people discharged, a third of the patients saw cardiology either in the ED or within 1 month. So even though they felt comfortable discharging people, that was with the fact that they had close cardiology follow-up 1 in 3 times. Now, maybe with the results of this paper, they wouldn't have felt the need to do that. But I think that is important to say that just having the test itself didn't necessarily make people comfortable discharging these people and not doing testing, but having that close follow-up, which I'm not sure that we'd necessarily get. So there is at least a question of the reproducibility.
Yeah, so as Siegler said in the chat, it's sort of like MOBAP or Barnes, where you can get them early follow-up.
Right. Yeah, between the cardiology follow-up and a family physician follow-up for 30 days, that accounted for 60, almost 70% of the patients. So yes, much better follow-up than we have at Barnes, but not unsimilar to what you would have at MOBAP or St. Peter's or West County.
Yeah.
The other thing I think it's important is that, a lot of us hang our hat on saying, well, the tropes are negative, but I'm going to get a stress test because that'll really prove whether they have any harm. And the stress test itself, whether you stress them or you get a spec MIDI or whatever, they're not a perfect test. And even if you have a negative exercise stress test or a adenosine test or a FAL or whatever, you're still at about 2%. And so their argument was, if the best you can get with additional objective testing is 2%, and with this biomarker, you're at that same level of certainty, then there's no reason to get the additional testing because it doesn't add any more clarification. It doesn't change your post-test probability in the patient because the biomarker is almost as good as the stress test. And so one of their arguments was, should we now be looking at it saying, the old adage of, well, they're less than 0.03, and so I still am uncomfortable, I'm going to get a stress test now to make it even lower, has changed. And so do we need to do those additional stress tests? And that's part of what they're pushing here, even though they didn't actually do the testing and say what the outcome was.
Other thoughts and comments? All right. All right. Who is presenting for the interns, and are you ready?
I am ready.
All right, Arthur, welcome. Whenever
Okay.
you're ready, go ahead.
All right, so the paper that I'm going to go over is the diagnosis of myocardial infarction using a high sensitivity troponin I 1 hour algorithm. So this is out of JAMA in June 2016 by Johannes Neumann et al. So the objective of this study is pretty much what the title says. They want to test a 1 hour algorithm to diagnose and exclude acute MI using this new high sensitivity troponin I assay. So essentially how they did this study. So let's get a little background on what they're doing now. So reading what this hospital in Germany is doing now is kind of similar to what we do here. They have what this high sensitivity troponin T assay with a cutoff of 27, which according to Dr. Char would be like equivalent to like a 0.027 here, which is kind of like what we're doing. And they do a 1 hour and 3 hour test. So what they're trying to do here is replace that with a 1 hour test at a lower cutoff, which they defined as 6, which would be equivalent to a 0.006. So how they did this was they essentially prospectively recruited 1,040 patients presenting with acute chest pain in the emergency department at this single center in Hamburg-Eppendorf, Germany, over about an 18-month period. So the only inclusion criteria for these people were that they were over 18, they had acute chest pain or other symptoms not well defined in this paper suggested acute myocardial infarction, and they were willing to participate in the study. It looks like the only people they excluded here were people with STEMIs, so EKG ST elevation changes. Essentially what they did here was they took blood draws at admission, 1 hour and 3 hours, and they drew assays for the new Troponin assay, as well as their current high sensitivity troponin T, and they compared this new diagnostic cutoff of 6 compared to what their normal standard of care would have been. And they defined that basically as any available clinical, laboratory, and imaging findings in the course of the hospital stay. And how this worked was they had 2 cardiologists who were blinded to the study troponins who gave a diagnosis of essentially NSTEMI or no NSTEMI. And then they had a 3rd cardiologist they called in if they disagreed. Let me go down here real quick. Sorry. So looking at like the patient population in there, average age of 65, hypertension in 70% of the people, diabetes in 15%, so pretty standard. They didn't really have any exclusion criteria, so they included all comers coming in, as I mentioned, except for the people with STEMI. And then they basically wanted to look at how does that compare to their normal care with the secondary, outcome of all-cause mortality at 12 months. So interesting outcome there. What they found out was, compared to their standard of care that they were using before, there's a negative, I forgot to mention that how they defined a positive AMI. So there's kind of like, essentially it was kind of like 2 studies done here. They did a less than or equal to 6, and they had the positive AMI defined as somebody with a value of at least 6 plus a delta of 12. So somebody essentially with like dynamic troponins. So somebody came in with a troponin of 10, and then they had to at least have a troponin of 22 at the follow-up to find that it was a dynamic change. So you have these 2 different groups essentially here, and then you have this area in the middle that fell nobody. So the results of that being that they found that according to that, the rule out troponin I assay had a negative predictive value of 95%, which is pretty good. And the other side of that, the people who had a positive AMI according to their criteria had a positive predictive value of 87%. So they have this kind of table in here, which kind of defines the 3 different populations. And essentially what they found was out of the 1,040 people there, they were able to rule out 406 based on they had this cutoff value of 6 or below. In addition to that, they were able to have 116 who they had this outcome of having a troponin greater than 6 with a delta of 12. So that left about 40% of people in this gray zone group who had an elevated troponin above 6, but without the qualification for that dynamic change. So looking at the result.
Sorry to interrupt, but what did they do with that? Basically 40% of the population that was in this gray zone.
They don't really say.
Yeah,
So they're exactly. Yeah, it's interesting. So this study didn't define a lot of what happened throughout the course here. Like I mentioned before, they didn't really define a lot of how they defined the gold standard of diagnosing STEMI. They just said we use a clinical course based with EKG imaging studies, et cetera, et cetera. So in this gray zone group, interesting fact was going to their secondary outcomes. They defined the people who they were to rule out, 4 people died. So it was 1% mortality. The people who had acute MI, according to them, which they didn't say what happened to them, whether they got cath, whether they got any PCI or anything like that. They don't mention that in the paper, but they said that there was a 6.7% mortality. Interesting enough, the patient population we probably care about the most, these gray zone people in the middle, ended up having 31 people die, which is like an 8% mortality, which they said wasn't really statistically significant from the people with diagnosed AMI, but still pretty, significant to talk about.
Yeah, it's concerning. The thing that bugs me here is they did a 3-hour algorithm and they still had 40% of their population that they didn't have a decision on what to do with. If you were to implement this in the real world, what are you going to do? You're going to admit all those people. That's almost half of the patients presenting with chest pain are going to end up admitted. I hope we don't do that in our institution. Maybe we do. So
yeah, and again, this comes back to what we talked about before, that they are only taking laboratory value into consideration with this. They're not taking the clinical picture, the risk factor. So what happened to those people in the middle? I'm sure there was a mix, but this paper really doesn't go into that. So that's essentially the gist of this study, how they did it there. And they kind of came to the conclusion saying that it is safe to discharge people, excuse me, with this cutoff value of 6, and then do whatever you would normally do, I guess, with these people who are diagnosed as having an AMI based on their criteria. Again, this didn't have a great follow-up in terms of what happens here. And it was interesting to me they used just mortality at 12 months as a follow-up, not like, MACE as in the other study or anything like that. So you want me to go into the diagnostic paper thing now? You guys okay with
go
that?
through the critical appraisal form now. I think that was a good
Sure.
sign.
Okay, so yeah, so anyway, did the clinicians face diagnostic uncertainty? Sure, so yeah, so I mean, if you're gonna say that they were uncertain about discharging people at 1 hour, yeah, I mean, I think there's some diagnostic uncertainty with this. Having this new assay, then yes. So was there a blind comparison with an independent gold standard? So I don't know if it was similarly applied to all patients, because again, they didn't define it well, but assuming that they're using the standard criteria to diagnose acute MI, which is this troponin changes along with, symptoms of ischemia or ECG changes or pathological Q waves or whatnot, then yeah, they did compare people, because the other group was blinded. The assessing cardiologists were blinded to the study troponin value. So I guess you could say they did use the gold standard there. Did the results of the test being evaluated influence the decision? So no, because they didn't use those actual study troponins in the clinical decision making of the patients. So that was not a factor. Looking at the likelihood ratios, so this gets a little kind of complicated because there were essentially 2 groups. So you have your positive likelihood and negative likelihood ratios for your rule out. So essentially you have a positive likelihood ratio of 2, saying that the odds of not having an end-STEMI with a trope less than 6, you're twice more likely not to have an end-STEMI. So there's still a huge group who are not able to be ruled out in that middle gray area. Conversely, the negative likelihoods is much greater, ends up being 0.04, which means you're 25 times less likely to have an end-STEMI with a trope greater than 6. So that's a good thing, which kind of makes sense, right? A high sensitivity, so you're ruling out a lot of people. On the other end of the study, using that 6 plus delta 12, had a positive predictive value of 87, which led to a positive likelihood ratio of 30, meaning you're 30 times more likely to have acute MI with that 6 cutoff plus the delta of 12. And the negative likelihood ratio ended up being like 0.41, which means 2.5 times less likely to have an end-STEMI with the trope greater than 6. So there's that. Will the reproducibility of the test result and its interpretation be satisfactory in my clinical setting? Yeah, I mean, this is kind of complicated. I guess, yes, you can say it will be, assuming that the logistics of the test are able to be implemented in our setting. You need a draw at admission, a draw at 1 hour, and a draw at 3 hours. So I think that we could implement that in our setting and it would be satisfactory. Now, are the results applicable to the patients in my practice? So I think there's 2 factors of this. So the patients in our practice are obviously much different, right? This is in Germany where they don't really break their demographics down to race, but I'm assuming most of the people there are white. An interesting factor, the average BMI in their study, although not statistically significant, was 26. I doubt that's what we're seeing here at Barnes. In addition, it's a completely different healthcare system. So I think that, you know, in Germany, I don't know a lot about the dynamics there, but I'm assuming that it's in Europe that they have kind of socialized healthcare, at least better follow-up than we do here. So I think that takes into account a little bit the fact they use mortality as their outcome and not MACE, because I don't know how many of those people who died in 1 year ended up having like 3 different stents placed in that same time because they didn't use that as an outcome, which might not be as big of a deal in a country where everyone's getting follow-up and everyone has good care, compared to here where a lot of our patients might be lost to follow-up after that initial discharge. So I don't know, I think that's something to think about. But so there's obviously differences there in that. So going down to, will the results change my management? I mean, if we get the high sensitive troponin, it's going to have to change my management. So I would say yes. I don't feel completely comfortable. I mean, based on my limited clinical experience, if someone came in with crushing substernal chest pain with a ton of risk factors, but the troponin is less than 6, the evidence here would suggest that I can feel comfortable sending this patient home. I don't know that yet, but so I don't know how I feel about that. And will the patients be better off as a result of this test? So I don't know if I can definitively say just off this test right here that our patients will be better off. So the benefits of this test, I think, really come in the form of less unneeded workup. If we're able to discharge people in an hour, as opposed to more people getting unnecessary caths, unnecessary hospital stay, unnecessary time sitting in the ED, will there be a better less financial burden on the hospital system and the patients possibly? But as far as outcomes go, I can't definitively say, because what we have is the patients we're discharging getting a 1% mortality. I don't have a lot to compare that to. Right now, if we have a patient who we clear by heart score of less than equal to 3, right, we're saying those people have a risk of major cardiac event of 0.9 to 1.7. So I don't know. I mean, that's kind of comparing apples to oranges to me, but especially in the different healthcare systems. But that's about all I got.
Excellent job. I think that's a valid point, though, is this idea of risk stratification, and we'll talk more about that in a minute.
So,
thoughts, comments?
Arthur, what did you think about this gray zone group? So those are people who didn't have a positive threshold, but didn't have negative or less than 6, right, at either time 0 or at 1 and 3 hours, and didn't have a delta troponin high enough to cause it to flag as well. So they weren't negative, but they weren't positive either. And so that's that gray zone. And right now I would argue that almost all our patients are in that gray zone, which is why so many of our patients, they say, well, your trope was negative, I'm still admitting you, because there's that uncertainty. So in this case, at least, they were able to get, able to discharge theoretically a fair number of patients that we would probably be routinely admitting, even if it's overnight for a stress test.
Yes. So, I mean, they don't really say what to do with these patients with the gray zone. So it is very interesting, obviously. Like what do you do with a patient who came in with a troponin of 10, but had a dynamic change of 10, right? That doesn't meet their criteria technically. They could kind of sit there in this gray zone. They don't mention, do they get another troponin?
That wouldn't be positive. The individual would already be over the initial threshold of 6.
Right, but they mentioned in the study that doesn't qualify as an AMI. They mentioned to qualify the AMI has to be over 6 with a dynamic change at 1 hour.
Right.
Of 12. So if that patient had a smaller dynamic change than 12, then they wouldn't be included in this positive AMI arm.
Right.
So
they're still in this gray area, which I don't know what to do with at this point.
Well, and they note is a lot of the gray area, there are other things that cause, as we're now learning, that cause a rise in troponin, not just STEMI or NSTEMI. So if you have heart failure, if you have a PE, if you're septic, so then the question always became, are some of those gray zone people, is their troponin elevated because of another cause, not necessarily traditional, ACS, thrombus or plaque rupture?
Yeah, and they tried to weed that out a little bit in their data by saying that they had a diagnosis of NSTEMI type 1 versus just all NSTEMI, assuming that they had another cohort of NSTEMI type 2, but they didn't give enough clarification on how they were defining that in the paper for me to kind of really include that in my data analysis. So unclear.
Thanks.
Good job, Arthur. Any other thoughts and comments from the crowd? All right. If not, I'm going to give a quick presentation, and I'm going to try and share my screen here so we can talk a little bit about likelihood ratios. Hold on just one second. Let me widen this back out. I'll just share my desktop. There we go. So quick talk on likelihood ratios and probabilistic reasoning, just what you guys wanted to hear about when you woke up this morning. So the problem is that we start with a person, we have some disease on our differential that we're concerned this person might have. So we run a test, we get the results of that test, and then we're left with this big question mark. Does this person have the disease or not? If tests were perfect, obviously it would be easy. The test would be positive and they had the disease, or the test would be negative and they don't have the disease. Unfortunately, as we all know, it doesn't work like that. So when we run a test looking for a disease, what is it based on those results? What do we want to know? Somebody tell me, what do we want to know based on the results of that test? Anybody? I know this is Zoom, but somebody shout it out.
So Dan Greenstein says,
Is everybody muted for some reason?
let's see.
Does it increase the likelihood of, or decrease the likelihood?
Okay, does it increase the likelihood or decrease the likelihood? Here, let me go back to this. Okay, so it either increases or decreases, but what do we really want to know? We want to know, based on the results of our test, what is the probability now that our patient has the disease? So you're right. So the test is either going to increase or decrease the likelihood based on the results. So the question now is, well, now what's our probability that our patient has the disease? So we have different test characteristics to try and help us answer these questions, but they don't necessarily tell us what we want to know. So we often think of sensitivity and specificity as being our go-tos, but sensitivity is the probability that somebody with the disease will have a positive test. Well, that doesn't help me clinically, does it? Because I don't know if the patient has the disease or not. And I don't care what the probability of the test coming back positive or negative is necessarily, at least clinically. I have the results of the test. I know if it's positive or negative. Now I want to know if the person has the disease or not, or what probability they are of having the disease or not. Specificity has the same problem. It's the probability that someone without the disease will have a negative test. Same problem. I don't know if they have the disease, and I already know what the results of the test are because I got the results back. So that leaves us with predictive values, which on the face of it are going to look perfect. Because what does a negative predictive value tell us? It's the probability that somebody with a negative test does not have the disease. That sounds like exactly what we want, right? And a lot of these studies report negative predictive values for that very reason, because it sounds on the face of it like that's the answer we want to have. And I'm going to show you guys why there's a flaw there. Positive predictive value, by the same token, is the probability that somebody with a positive test has the disease. It seems like it answers our question, but again, there's a problem there. So the problem is prevalence. Positive and negative predictive values vary as the prevalence of the disease varies. So we're talking about the same test in both of these figures here. This is the same test, but in two different patient populations. The sensitivity and specificity of the test are 95%. That doesn't change with the prevalence of disease, at least in theory it doesn't. And you can see in these two squares here that the sensitivity and specificity are the same. But what about the positive and negative predictive values? Well, here on the right, we have a very highly prevalent population. So the disease is present in 95% of the patients in this population. As a result, if you do the test on a ton of people most of whom have the disease, and it comes back positive, well, it probably means they have the disease. So again, a positive predictive value of greater than 99%. But again, very few patients in this group had the disease. So the negative predictive value was awful, only 50%. On the other hand, on the left here, where our disease prevalence is very, very low, only 5% of patients had the disease, our positive predictive value now is only 50%, whereas the negative predictive value is great. It's greater than 99%. As some people will say, if you do a test on a bunch of people who don't have the disease, it's probably going to come up negative in most of them, right? So we now are stuck with sensitivity, specificity, which we said don't answer our question. positive and negative predictive value, which seem like they do, but they don't take into account the prevalence of the disease in the population. So we need something else. Our ideal test is something that's going to take into account the pre-test probability of the disease or the prevalence in our group of patients that we're specifically looking at. Then once we have the test back, we know or find out what our post-test probability of disease is, the probability of the disease now that we know the results. And this is where likelihood ratios come in. Does anybody know who this is? I'll be shocked if anybody does. It is not Greg Politis. Looks a little like him. So this is Thomas Bayes, who is a famous statistician who came up with Bayes' theorem or unconditional probability. You don't have to worry too much about what this is, but basically what this says is that the probability of A being true, given that B is already true, is equal to the probability of B being true if A is true times the probability of A divided by the probability of B. Now that's just a bunch of nonsense, but if we throw in there diseases and tests, it starts to make a little more sense. So now we have the probability of the disease being present if the test is positive on the left, our post-test probability. And on the right there, we have the prevalence of the disease, our pre-test probability. And what this allows us to do is to use this formula to create likelihood ratios that are going to help tell us the probability of disease based on pre-test probability after the test comes back. So likelihood ratios. These are the formulas for them. You don't have to memorize them, but they're good to know. Positive likelihood ratio is the probability of having a positive test if you have the disease divided by the probability of having a negative test if you have the disease. Negative likelihood ratio, on the other hand, the probability of having a negative test if you have the disease divided by the probability of having a negative test if you don't have the disease. But more importantly, let's talk about how they're used in application, because that's what we really care about. So you start with a person, you run a test. Now that you have the test back, you can figure out the post-test probability by applying these likelihood ratios to the pre-test probability. So the test comes back positive, your pre-test probability, and you can use that to figure out your post-test probability. And let's show you how you do that. So there are a couple of ways. Oh, wait, hold on. Same thing with negative tests. This is all this is. We'll run through that. First is this Phagon Nomogram. So Arthur, when you were talking about likelihood ratios, you said something to the effect of that if your positive likelihood ratio is 25, that means you're 25 times more likely to have the disease. That isn't really true. Your odds of having the disease are actually 25 times higher, which is hard to think through, but it's not like you take the pre-test probability of say 2%, multiply it by 25, and now your post-test probability is 50%. It'd be nice if it were that easy, but it's not. This Phagon Nomogram, though, allows you to start with the pre-test probability on the left, draw a line through your likelihood ratio, and you'll end up at your post-test probability. In this case, if your pre-test probability is 10%, you have a positive likelihood ratio of 10, your post-test probability is a little higher than 50%. So now your test came back positive. I now know that you're a little more than 50%, have a little more than 50% chance of having whatever disease it is we're looking at. So you can use the Phagon Nomogram for negative likelihood ratios as well. If you start with a 25% a 25% probability of disease is your pre-test probability, negative likelihood ratio is 0.2. Now your post-test probability is 5%. So we've reduced your risk by having a negative test. You can use these Phagon Nomograms, or you can use online calculators, which are much easier to use and are going to give you a more accurate result. There are a bunch of them online. These are just a few. So let's apply this real quick. Or sorry, before we get to that. So what's a good likelihood ratio? There's no absolute number. We tend to think of positive likelihood ratios greater than 10 as giving us a large change in the probability of disease when the test is positive, and a negative likelihood ratio of less than 0.1 is giving us a good large decrease in the probability of disease. For a positive likelihood ratio, a 2 to 10 is kind of moderate. 1 to 2 is pretty small change. For negative likelihood ratio, 0.1 to 0.5 is moderate. Anything between 0.5 and 1 is a small change. And again, a likelihood ratio of 1 means there's no change in probability. So how do you figure out what someone's pre-test probability is? Either by knowing the known prevalence of disease in a patient population, so probably more applicable to oncologists and cancer, using clinical gestalt, or by using clinical decision rules, and we'll talk about how we do that. So let's talk about real quick, we're going to talk about our patient in our vignette. Pull up our heart score calculator again here. So I think I wrote in the vignette that the patient had a heart score of 3, and someone pointed out it was actually probably 4 because they had moderately suspicious of disease. They were between 45 and 64. They had greater than 3 risk factors. So heart score of 4, which puts them at a 12 to 16.6% risk. So going back to the PGY 2 study, pull up the numbers here. If you had an initial troponin less than 6, your negative likelihood ratio for the disease was 0.17. So if we apply that to this patient, we're going to enter a risk of, let's say 15%, which is between that, what was it, 11 to 16, or 12 to 16.6%. And now a negative likelihood ratio of 0.17, which I'll put right there, and we calculate the risk. So now if the test is negative, the post-test probability is 2.9%. Now they've mentioned a negative predictive value of over 98%, so your risk was less than 2%. But again, that's all comers. If we look at a patient who's at more of a moderate risk like our patient, we're still at about a 3% risk of disease. If on the other hand, we looked at a patient who was coming in with that crushing substernal chest pain while they were shoveling snow, which is just a high risk thing for someone who's over 65, even with a normal EKG and a bunch of risk factors, and some non-specific changes on their EKG, now their risk is more, their pretest risk is 50 to 65%. So this is a high-risk patient. And if we enter that pretest probability of 50%, even with a negative diagnostic test, even with a negative initial troponin, our risk is still 14.5%. So even though that negative predictive value was greater than 98%, if we're looking at moderate to high risk patients, our risk is higher than that 2% that they are touting. So you have to be careful. You can't apply these numbers, these negative predictive values, to all patients. If you do that, you're going to miss the disease in a lot of the sicker patients and the ones who are higher risk. So that's why likelihood ratios help us a lot more than negative predictive values, because they take into account the pretest probability or prevalence of disease in particular subgroups of patients. So one last thing, and then we'll be done with this, is you don't have to use a strict cutoff when you're using likelihood ratios. You can actually use something called an interval likelihood ratio. So here, we're looking at white counts for patients with appendicitis, rather than just use a cutoff of, say, 10 or whatever it is. I think it's 10 in our institution. If you have a white count less than 8, you can see that your likelihood ratio, negative likelihood ratio, is 0.2. If you have a white count of 8 to 15, you now have a slightly positive likelihood ratio of 1.3, and a white count greater than 15, your likelihood ratio is up to 7. So you can break these down to whatever intervals you want. Keep in mind, the more intervals you have, the smaller number of patients in each group within that interval, your 95% confidence interval for your likelihood ratio is going to be wider and wider. All right, let me unshare here. Any thoughts or comments or questions on that? The main thing here is when you're looking at diagnostic tests, don't just rely on these negative predictive values that they'll often hand you. They can say a negative predictive value of 99% means that only 1% of patients with a negative test have the disease, but that's all comers. If you take a high-risk patient, their probability of having it is going to be higher. Low-risk patient, their probability is going to be lower. Questions, thoughts, comments, or are we ready to move on to the third year paper? All right, third years. Who's presenting for us?
I think it's me.
All right, Katie.
Well, I tried to get my video to work, but for some reason it's angry. That's okay. So my paper was the diagnostic accuracy of a new high sensitivity troponin assay and 5 accelerated diagnostic pathways for ruling out acute myocardial infarction and ACS. So a brief, I guess, summary of this paper. So I'm sure you guys are all familiar with the heart score, but did you know there's actually like a bajillion other scores This study included 4 other ones. So they included this one called like the new Vancouver chest pain, I guess as opposed to the old Vancouver chest pain. They included one called like the NOT, that stands for no objective testing, one called like M-ADAPT, and then another one called EDAX. And they were looking at those plus this new high sensitivity troponin, I guess to see if the 2 in conjunction could actually reach a desired endpoint, which for them, they actually split it between acute MI within 30 days or ACS within 30 days. Let's see here. And so their high sensitivity troponin assay that they used, their 99th percentile was 17.5 nanograms per liter with a limit detection of actually 2.3. And then they actually had sex specific cutoffs. So they had like 11.6 for women and 19.8 for men, which they also further divided the data into. The way they did the study, so they actually pulled data from 2 older studies in Australia. So one of the studies was like from 2008 to 2011. It was a prospective observational study that was, I think, specifically focusing on the ADAPT score. And then the second one was a little bit later, and it was an interventional study with a subset that was actually already receiving the high sensitivity troponin at 2 hours instead of the standard troponin I that they had is 6 hours. And that one, so the older one had about like 980-ish patients, and then the second one had about like 1,300-ish patients. And they basically combed through this data and retrospectively classified the patients using those decision tools. And then they checked 30-day outcomes. And I think, and correct me if I'm wrong, from when I was reading the paper, they, I guess like still had the blood available. So they were able to like go back and like retroactively check this with the high sensitivity troponin assay on those patients that they included at 0, I guess, and whatever hours they were checking at the time for those studies. So ultimately, they ended up with about 1,800 patients. And in that group, 5.3% had an acute MI within 30 days and 7.7% had ACS. Of all of those patients, 1660 had a high sensitivity troponin below the 99th percentile. And then of those 1660, 30 actually had an elevated repeat high sensitivity troponin. So they ended up with 1630 in total that had basically like initial negative troponins, high sensitivity troponins. And then of that 1630, 10 had acute MIs. And then they kind of further divvied that up looking at these 5 different, I guess, decision pathways. So I started with the heart score. I guess they had 2 false negatives that had acute MIs using that decision pathway with the high sensitivity troponin. And then they had 7 false negatives when they were looking at ACS. For the New Vancouver score, they had 0. They had 0. They had 0 acute MIs, and then they had 2, I guess, false negatives when it came to trying to rule out ACS. For the NOT, they had 0 missed MIs basically, and then 1, I think, missed ACS. And then for the M-ADAPT, they had 3 that false negatives for acute MI and 10 false negatives for ACS. For EDAX, they had 2 false negatives for acute MI and 11 false negatives for ACS. So they mentioned some limitations. So they, I guess, with these studies that they had previously done, there was actually like a even larger cohort of patients, but they excluded some people because I think they couldn't run the high sensitivity troponin assay or they didn't have that data for them. So they excluded a number, like an entire subset from New Zealand. They also didn't really do the heart score the way I think it's originally intended, and even mentioned that they were just kind of trying to go back and calculate it, and it was kind of missing the original, I guess, clinician subjectivity. They also like only included patients back in these former studies with like business hours. So they were only like looking at people from like 8 a.m. to 5 p.m. And then all in all, they had like a pretty low prevalence of acute MI and ACS within like the entire population. The conclusions that they drew were basically that if you use the high sensitivity troponin and you're using, I guess, either the new Vancouver chest pain or this NOT score, you can safely discharge about 1/3 of your patients with no further testing like whatsoever. However, with the other testing modalities, including the heart score, they said even though you could count more people as low risk, ultimately these people who were discharged had to be referred for like quick follow-up and more objective testing. That was my summary of the 16-page paper. I'm sure I left some stuff out, so feel free to chime in, Dr. Cohn or Dr. Char. If not, I'm going to go to the diagnostic form.
Okay, so I think you did a good job. This is a really complicated paper. It took me a long time to sift through it. So I think they've given you 5 protocols here, right? EDAX, ADAPT, heart score, and then the New Vancouver and the NOT, or the no objective test. And as they say in the beginning, it's important to realize that each of the scores was looking at a different population. So the EDAX and the ADAPT, and they were one of the ADAPT sites, which is why they have all the data, goal was to rule out or rule in AMI quickly. So they're focused on AMI, not necessarily all ACS. Whereas the heart score, the NOT score, and the New Vancouver were really were set up to say, can we identify low-risk people who we can send home without doing anything else? So they're looking at ACS, a broader category than just MI, and their goal is to say, send home, don't do anything. Whereas the EDAX and the ADAPT's goal is identify AMI, and if not, then be able to quickly move on to objective testing, i.e. stress testing, cath, anything else you want. So the protocols were looking for different populations, and that's why they did all this calculation both for AMI as well as for ACS, because they said the protocols have 2 different endpoints that they were designed for, and we don't want to use them incorrectly. Now, as you said, when you gum it all together, there's crossover, right? So that if you're the NOT or the New Vancouver and you're negative, you're good to go. I mean, they're like 100% sensitivity for MI and for ACS. They're like great. But if you apply it, a very small proportion of the population would meet those criteria. So the majority, 2/3 of the patients, you'd still be stuck with going, now what do I do? Do I have to admit them? Whereas the EDAX and the heart and the ADAPT weren't as sensitive, but it captured a lot more people, between half and 2/3 of the people. And so you could apply it more broadly. And so again, it's that tension and that give and take between, I'm really comfortable if they're negative for New Vancouver or for the NOT, but that I can only apply it to about 1/3 of the population. Whereas if I apply an EDAX, an ADAPT, or a heart score, I can apply it to more than half of the patients, which gives me an answer for a lot more people, but with the assumption that I may have to do additional testing. All right, sorry.
No, that was helpful. All right, I have the diagnostic test form pulled up. The first question is, did clinicians face diagnostic uncertainty? I wasn't totally sure how to answer this. I'm sorry, that's gonna be like a common theme for this. But I felt like the data was pulled from prior studies that they had done. So I'm not entirely sure that they had a ton of diagnostic uncertainty, because I mean, it's all old data and the outcomes were kind of already known.
So Katie, the question is, did clinicians, so not the investigators, so if you're the clinician taking care of this patient in your ER, do you know if this person in front of you is having an MI before you do any of the testing?
No.
Yeah, so I mean, the people taking care of the patients in all these studies were just like us trying to take care of our patients in our ED. Someone comes in with chest pain and you're faced with diagnostic uncertainty, right? Are they having an MI? Are they having ACS? Is this angina? Is this musculoskeletal? So that's what that question is asking, is the clinicians who are the ones deciding what test am I going to order, did they face diagnostic uncertainty, or did they have ESP and just knew what this person had?
Gotcha. So in that case, yes, diagnostic uncertainty. And then was there a blind comparison with an independent gold standard applied similarly to all of the patients? So I probably answered this one wrong as well, because I was still kind of looking at it within the framework of the study, because I wasn't sure. I was like, which of these 5 decision pathways gets to count as the gold standard? But I guess if you look at the individual studies that they used, I believe that they were, at least the one where they were trying to include the new high sensitivity troponin, they were comparing it to, I guess they had like an adjudicator troponin I think that they were including. So they did, I guess, have some sort of gold standard in place. But yeah, not sure.
Yeah, it's tough because the gold standard in these studies, there's no real gold standard for MI or acute coronary syndrome. So the gold standard was whatever outcome they were looking at, and how did they figure out whether or not someone had that outcome. In this case, for the most part, you know, the way they're figuring out if someone had the outcome of interest is the same for all the patients. It's not like when you're looking at something like a AAA, you know, we want to look at the diagnostic accuracy of bedside ultrasound for AAA. Well, the gold standard in that case would be, right now at least, a CT angiogram. It used to be a formal angiogram, but probably a CT angiogram is your gold standard for diagnosing a AAA. In this case, where it's a little more nebulous, there's not a true gold standard.
Cool. And then let's see, did the results of the test being evaluated influence the decision to perform the gold standard? I guess if there isn't really a gold standard, not totally sure how to answer this one as well.
Well, again, did the results of these high sensitivity troponin tests, did they influence how they figured out if someone had an MI or ACS down the road? If you have a positive troponin, you're more likely to get a stress test or a cardiac catheterization?
Yes.
Probably, yeah. So in a way, yes, unless they blinded everybody to the results of all troponin, which they couldn't really do, the results of the troponin, if not the assay that they're studying, at least some assay, was going to influence how you did further testing down the road, which is sort of, again, there's not a true gold standard. But if my gold standard is, you know, revascularization, and I don't do a cardiac cath on anybody with a negative troponin, but I do a cardiac cath on everyone with a positive troponin, then the results are going to influence how many people are diagnosed or undergo revascularization. People that I didn't cath, the ones with the negative tropes, none of them got revascularized. The people that I did cath, even though some of them probably had stable 70% lesions, some of those people got revascularized. So the results influenced whether I diagnosed you with the outcome that I was concerned about.
Gotcha. All right, and then the next question is about likelihood ratios. So good thing we just had that PowerPoint. It was what likelihood ratios are associated with the range of possible test results. So in this study, so I guess they had the 5 decision pathways, and then they also had acute MI and ACS, because like Dr. Char talked about, a couple of these were built basically to look specifically for acute MI, and then the other 3 were more looking at MACE within 30 days. So they included all 5 of them, though, within both subsets. I attempted to calculate the likelihood ratios, but I don't know if you want to sit and listen to me rattle off a bunch of numbers. The gist of it was that the positive likelihood ratios I got for almost all of these basically were like anywhere from like 1.5 to 3, with the Vancouver chest pain and the NOT one being on the lower side. And then the MADAPT and EDEX and heart being like in the 2 to 3-ish range. And that was consistent for acute MI and ACS, whereas like the negative likelihood ratios, I mean, for Vancouver and NOT were 0, essentially. So super, super, super low. And then for the other 3 were like a slightly higher, but still pretty low, like 0.03 to 0.05. And this was consistent, again, kind of between acute MI and ACS. It was a little bit higher, I think, on the negative likelihood ratio for those.
All right. Yeah, no, I think that's pretty good for the likelihood ratios. I don't think you have to give us all the exact numbers.
Great. And then the reproducibility of the test and its interpretation be satisfactory in my clinical setting. Well, the way I answered this was, to be honest, I really haven't heard of most of these other decision pathways. I pretty much only use the heart score. And according to this study, at least what they said in their conclusion was that they were concerned it didn't achieve the 99% sensitivity for ACS or AMI that clinicians want. They did also, though, acknowledge that, again, that the way they used the tool was not as it had been originally intended. And then with regards to the high sensitivity troponin being thrown in there, I'm not like sure as far as like if it would really impact, I don't know, what I would do, or if it would change how, I guess, satisfied I feel in my clinical setting. I still feel like I'm going to use the heart score. And if the high sensitivity troponin comes into play, then likely use it in conjunction with the heart score.
I think that's fair. Again, this was a retrospective use of the heart score, which is tough because the first question is about your clinical gestalt, and they can't measure that retrospectively without, you know, with your low suspicion, moderate suspicion, high suspicion, you know, story. There's no way to do that. So it's hard to use it when you're doing a retrospective study and get an accurate sense of the likelihood ratios for it.
All right, and then are the results applicable to patients in my practice? Kind of like both Muris and Arthur brought up, we don't really have a high sensitivity troponin yet, although I think I saw one when I was out in the community and I was really confused by the numbers coming back. That was not what I was used to. So maybe we'll have one at Big Barns. You know, I think with the heart score, what did they have? They had like 2 false negatives that they missed for acute MI and then 7 false negatives for ACS. It doesn't seem to be a great miss rate. But again, like Dr. Char mentioned, I think the point of the heart score is not necessarily to completely rule it out, but, you know, to also help establish who should get, you know, a quick referral for follow-up. Again, that's tough for us at Big Barns, but having spent a month out in the community, it's actually much more obtainable there. So I guess ultimately, very circuitously, I feel like the results are applicable if we should get the high sensitivity troponin here at some point. I don't think the next question was about if this would change my management strategy. I don't think necessarily. I really don't think I'm probably going to like start busting out the Vancouver chest pain anytime soon. I like the heart score, unless someone much smarter than me tells me that it's a lot better and that I should use it. I probably won't use it. The last question is, will patients be better off as a result of this test? I think this was also mentioned, but you know, the fact that if we can maybe do like 2-hour troponins instead of 3 or 6 hours, that might help with throughput, might help our, I don't know, our boarding situation and ultimately help all patients. But other than that, I'm not entirely sure how much better off patients will be.
All right, good analysis. Thoughts, comments?
So just really quickly, with regards to the heart score in this one, it was interesting, the author's conclusion that that the heart score doesn't really hit their like less than 1% or like 99% sensitivity. But in previous studies, like we've seen the heart score prospectively validated with like 99.5% sensitivity. Do you think it's just a function of the fact that they weren't doing this prospective and this is more retrospective?
I think it's probably mixed. The heart score, depending on, again, there's a certain amount of gestalt. So if you give the heart score to a bunch of interventional cardiologists and you say, listen to the story and then apply the heart score, you may get a different score than if you give it to a bunch of EM interns who have a limited clinical experience and you say, I want you to listen to the transcript of the patient, how they describe their chest pain and tell me whether you think it's low, medium, or high. And so there is some wiggle room there. And that's been one of the arguments of the heart score, why they developed things like the New Vancouver and the non-objective test, is that it doesn't rely upon someone's gestalt.
Yeah, there's definitely that component. I think the fact that they applied it retrospectively and could not accurately get that first component, that, you know, how concerning is this story, is part of it. Again, a sensitivity 99%, clinically, that doesn't tell me anything. That means that of 100 people who actually had ACS, 99 of them had a negative, of 100 people, of 100 people who had ACS, 99 of them had a positive heart score. That doesn't tell me much clinically. I care more about what the likelihood ratios are. But whatever they were, it's hard to know that they're accurate given how they applied the heart score in the study. Anybody else? Thoughts, comments?
I do think what they were trying to do was helpful in that they were trying to take a test, which we have already seen is pretty darn good, and said, by applying these rapid diagnostic pathways, does that make it better? You know, does it give you more comfort, or does it increase your ability to say, are they truly low risk, or are they gray, or are they high risk, more than just the biomarker itself? And I think that's what we all do in the real world, is we try to, you know, use a guideline like this and see if it'll help convince us, you know, either reinforce our gestalt or question our initial impression based on these pathways.
Yeah, and that's why I wanted to include this study. You know, you saw in the first and second year papers, they really just used troponin independent of everything else. No clinical picture to guide you, no risk stratification beforehand. Here, at least, they said, well, let's use it the way that we, as you said, the way that we use it in the real world. Let's risk stratify patients and see, using these high sensitivity troponins combined with a bunch of different clinical decision rules, how accurate is the test. So to address what I hadn't calculated this before, but to address what Sal said, you know, that they had a sensitivity of a little less than 98%, but the negative likelihood ratio is 0.04 for the heart score with the negative troponin, which is good. That's less than 0.1, which is what we want to see. So they may have had more of a problem with it, but I think it even with the concerns about the accuracy, it did seem to perform well.
So yeah, with that being said, with the negative likelihood ratio being so low, and the other ones like the Vancouver and I forget what the other one, the NOT one, like they're also very low, but then are they also capturing a lot of patients, or a lot of patients, I guess, screening positive that are going to get an unnecessary workup? So do we really, like, would switching over to those be more reliable, or does it just open up these patients to having unnecessary tests done?
Yeah, it depends on what the next step in your testing is. If the answer is, well, we're gonna keep them for a repeat 6-hour troponin and have a way of evaluating it based on that, you know, that's reasonable. Or if they're in this moderate risk group, if they, you know, they have a moderate risk heart score, they're not negative, they're not going to go home, or they're going to go home, but we're going to have them follow up with the cardiologist the next day. Or they're in that moderate risk group. Are we going to now make all of those patients who screen positive based on this undergo cardiac catheterization? It all depends on what the next step is. And I think we're still learning with high sensitivity troponin how to use those patients who are quote unquote positive when we have such a high sensitivity test that is not very specific. We have to figure out what we do with that, again, that gray zone, as we talked about in the first year paper. They had 40% of the patients were in that gray zone. I still don't know what we're supposed to do with those people. I think we have to come up with an algorithm. I think if your algorithm is that gray zone patient population just gets repeat troponins, you know, 6 hours down the road, I don't think that's necessarily the worst thing. Although if it clogs up our ER, it might be bad. But if they're all getting catheterizations, that's obviously more of a problem.
Right. And again, going back to the way that these pathways were developed, Hart, Vancouver, and the no objective test, their goal was to say, can we identify people who we just send home, but we stop everything, we don't do anything more, we send them home, Whereas EDAX and ADAPT were set up to say, can we identify, AMI early? And if you're not AMI, can we move you forward for more objective testing quickly? So it's a different population you're looking at. I will say that for Barnes, cardiology lab and myself and Rob Poyer and company have endorsed heart and then EDAX as the two scoring systems that we're including with all the new troponin rollout stuff, because we think those are probably the two best ones to use for our situation. And again, cardiology, lab medicine was more in favor of EDAX, whereas the ED, Rob and I were like, yeah, but what I really want to know is, can I send them home? So we liked heart.
Yeah. That's a very good point, Sal, that you raised there. All right, let's move on with the 4th year paper.
All right. Brian, can you do me a favor and let me share the screen here just for a spiteful PowerPoint?
That's right, your passive aggressive PowerPoint. All right, hold on one second. Let me figure out how to do that again.
It should be hovering over my name. You'll see more, and then you can add me as a host.
I'm not going to make you a host. I don't know about that.
You can make me a co-host.
Co-host. There we go. I'll make you co-host.
All right. All right. So here we go.
It's only temporary, though.
Only temporary. It's too much power for me. All right, everyone. Hey, how y'all doing? My article today was the impact of high sensitivity cardiac troponins on the use of coronary angiography, cardiac stress testing, and time to discharge and suspected AMI. Pretty big mouthful of a title, but tells you exactly what we're kind of looking for. All right, the reason I'm doing this, I guess it's technically a keynote presentation, not a PowerPoint, not to anger Jason, who's definitely not listening, is a special thanks to Pat Lanter. For those of us who were there last month, they remember Pat Lanter decided to make a presentation on PowerPoint, much to everyone else's chagrin. So thanks a lot, bud. You all know this guy right here. I decided, he can be a gunner. I can totally be a gunner too. And then when we started this entire journal club, I definitely saw that he wasn't inside the chat, which make me generally look a giant asshole. So anyways, what is the purpose of this paper? The clinical question they essentially ask is, do high sensitivity troponins lead to increased or inappropriate coronary angiography, stress testing, and how does it affect the time to discharge? The methods that they use for this is they use this giant APACE conglomeration of studies, which is the advantageous predictors of ACS evaluation, which has been going on essentially since 2006. This is an ongoing prospective observational study, and the inclusion criteria to be in this was chest pain or other symptoms suggestive of AMI with an onset of symptoms or peak within the last 12 hours. These people were generally over 18. And the adjudication of the final diagnosis, which I thought was kind of interesting when I looked into it, it was reviewed by 2 completely independent cardiologists who were able to actually review all the medical records and all the charts relating. So this particular study was essentially taking 6 different hospitals. In truth, most of it's going to be related into the 3 hospitals that changed to the high sensitivity troponins. And the other 3 hospitals you see, hospitals 4, 5, and 6, are essentially created as a control group to help with validation. But like I said, these 3 are going to be the primary areas of interest. They essentially said that they placed things into a phase A and a phase B. The times were generally staggered, but they compared slightly off times and tried to take into account for it. But they went from 4th generation troponins, which is what we're used to the high sensitivity troponins, the 5th generation troponins. So in general, between hospitals 1 through 3, those that stayed in phase A, which was the normal troponins, or the 4th generation troponins, there was 1,455 people. And in phase B, with the high sensitivity troponins, there was 1,089 for an N of 2544. How do these particular markers done? Well, they use the standard of care for the troponin at the time, and the 4th generation with 0 and 6 hours, and then with the high sensitivity troponin based on this 2011 European standards of a 0 and 3 hour marker. So getting into the brass tacks kind of what happened here, these are the baseline characteristics. As you can see, they were pretty similar. Maybe the ages were slightly different, or the risk factors of hypertension were different, but there's not a lot of major statistical differences between the groups, between phase A and phase B. They tried to take into account as many things as possible, and then you'll see these adjusted p-values later, which is when they went back and tried to correct things for things like pulmonary hypertension or arterial stuff. This was kind of interesting because looking back through one of the supplemental data, they made a comment within the literature that they were saying, well, using the new high sensitivity troponins, it looked like there was actually an increase in increase in diagnosis of AMI, but in general, the diagnosis of acute coronary syndrome remained not statistically significant. Here is the meat and potatoes of everything that they've went on. So going one by one here, one of the biggest things that they looked for was cardiac stress testing, which is in the main title of the paper here. What they actually noted is that cardiac testing as a whole, when they switched to the high sensitivity troponins, actually went down, and that was statistically significant. It didn't seem to change anything in the perfusion study stress testing, but specifically they stopped doing as many exercise stress testing as before. Not 100% sure why that was the case. There was not really a comment of why that happened. Relating to coronary angiography, it looks like it generally stayed the same. There wasn't a statistical significance between the two groups, so the advent of the high sensitivity troponin testing didn't seem to have any effect on whether people were getting cathed or not. The biggest thing that they ended up finding in here is that the duration of stay changed pretty significantly. For people that were getting discharged, this was a difference of like 77 minutes, and that was pretty statistically significant, and in general, things moved a little bit faster for them. So an hour less a patient, if we tried to extrapolate that into our kind of population, that's potentially, even in an era of boarding of seeing a bunch of people with, you know, moderate to low risk chest pain, that they might be able to get discharged a little bit faster. In regards to the cardiac stress testing, as I mentioned, there didn't seem to really be any, there seems to be particularly due just the exercise amount, no significant difference between the perfusion studies, and the angiographies remain generally the same. And this was just the results of the angiography in this particular figure. And they were essentially saying the distribution of issues or any pathology that they found were also the same whenever they did angiography for these people.
So Nico, why is that important?
Because essentially what they're saying is that we're essentially cathing for the same things that we've done before. Nothing has changed, and even the pathology itself isn't changing. It's saying that this new high sensitivity troponin is in benefit for here, not changing much pathologically. It's not inferior to previous generations of troponin, but if anything, it helps their time.
So my take is a little different. So their argument is that if this is a super sensitive test and you're still doing the same number of caths, then theoretically, are you going to be cathing a bunch of people with normal coronaries, people who didn't need a cath? And so in phase B, if you had seen the percentage of normal, the green, the normal vessels, i.e. they had a normal cath, go up, then you would argue that they're still cathing people, but they're cathing unnecessarily. In this case, because the percentage that are red 3-vessel and orange 2-vessel disease is essentially the same, that even with the more sensitive test and a lower cutoff, then the people that they're cathing are just as sick. They're not getting a bunch of unnecessary caths occurring.
Gotcha. So generally non-inferior, is that fair to say? Related to a lab test, at least. I know it's a little different than an intervention. All right. This particular graph was actually pretty complicated to look at. It was hard to just kind of understand due to the scale, but this is the general time from discharge from the emergency department, whether they go inpatient or not. And you can see with the dotted line, they ended up staying a little bit longer. The scale doesn't help to kind of show that 70-minute difference, but this is just another pictographic image of how that looks. This was the duration of stay in comparison to really when before they started the introduction. So the months before the hospital switched from phase A to phase B. This also took into account the time it took to train, to get people associated with it. So you can see there's probably a slight uptick before it gradually starts to go down in the following years. And I thought this was pretty interesting because this showed the general cost on it. And I think this will be the best way to kind of look at through the therapy form this way. But initially, the plot on the right is showing the hospitals that changed from from normal 4th generation to high sensitivity troponin, and the graph on the left, graph B, is actually showing the hospitals that ended up not changing. I'm not 100% sure why in phase B, the hospitals that didn't change, the general cost started to go up, whether that be due to inflation or not, couldn't really tell you. But you can see based on the hospitals that did change that trend, the total cost for that hospitalization seems to have gone down with time. Interestingly enough, as I was literally sitting here, like getting this paper or going through this paper, the Annals of Emergency Medicine last month actually had a similar paper, and I just love the fact that their conclusion was that the European rapid rule out, which is kind of what we're talking about here, can be harmonized with the demographically and with the demographics we have here in the United States. And this is actually an article, which is an update from the same authors that did this paper that I'm presenting here, of how they their typical algorithm for managing with these high sensitivity troponins. So, and this is just the hard pathway. I think we've talked about this in the past, so I'm just gonna skip on that. Going through the critical review form here, as I'm done sharing the screen. Where are we? I'll share. Going through it all here, the questions starting from the top, were the patients randomized? This really couldn't be done for this particular study. So that couldn't, that's a no. Were the allocations concealed? Was it possible to subvert the randomization to ensure a patient would be randomized to a particular group? No, the hospitals were different, so this was also kind of impossible to conceal as well. Were the patients analyzed in groups to which they were randomized? That's not available for this particular study. Were patients in the treatment and control groups similar with respect to known prognostic factors? So technically, they attempted to adjust for the multiple differences between the different hospitals, but there was no propensity scoring. So it was kind of difficult to really group the people. Were patients aware of group allocation? So this was kind of a tough one because I think we order troponins on everyone and we don't really think about that too much. In fact, in this paper, they made one line about it. They said, yeah, the patients were signed an informed consent. I couldn't tell you if that was an intent, consent to treat or consent to use high sensitivity troponins on them. Were clinicians aware of the group allocation? It has to be yes, because you now know you're ordering troponins at a different time period than you normally do. Were outcome assessors aware of group allocations? And they had to be, given how all the tests are ordered and the fact that the adjudicators had everything associated, or the cardiologists that adjudicated and adjusted the p-values had all access to patient charts. Was follow-up complete? I guess to a certain extent when you have the adjudicators going back through the data, but it's kind of irrelevant at this point. How large was the treatment effect to it? This is, once again, kind of difficult to determine without propensity scoring, since that's kind of like a mainstay of determining the treatment effect. It didn't really seem to be the purpose of this particular paper, though. How precise was the estimate of the treatment effect, i.e. what were the 95% confidence intervals associated with the results? This is tough. There was no confidence interval. There was no clinical effect that they were actually measuring. But based on what they could show, that there was statistical significance between them.
So for what was the primary outcome that they were looking at in this study?
Right, they were looking to see, were high sensitivity troponins actually adjusting our rates of cardiac testing, angiography, and does it affect our time to discharge?
Yeah, so
that's why.
Was there a difference in the rate of coronary angiography between the two groups?
Coronary angiography, no. Stress testing, it was yes, because they decreased the stress echoes, and then of course the time to discharge, yes.
And so can you figure out, based on the numbers they gave you, could you calculate a relative risk or an absolute risk reduction for each of those things and a 95%? I guess technically,
because we have a goal, because we have something to compare it to, sense of control, that we probably could. My math isn't that good despite being,
No one's, well, not no one's, most people are. But
you could, in theory you could, yes.
There are online calculators. You plug the number, the number of patients in each group in, and you plug the number who had the outcome. So the number who had a coronary angiography in group A, the number who had one in group B, and it spits all the information out for you. So for me, I got a relative risk for that of 0.98 with a 95% confidence interval from 0.85 to 1.13. Obviously, no difference. For overall rates of stress testing, they were lower in that phase B. In the second phase, as you said, the relative risk was 0.67 and the 95% confidence interval was 0.57 to 0.77. So clearly did not cross 1. So there was a statistically significant difference, a statistically significant reduction in the rates of stress testing. Just, you know, it's nice to have the numbers. It'd be nice if they reported those numbers themselves. I'm not sure why they didn't. But if they don't, and if you're looking at a study and you're like, well, I want to know what the actual effect size was, and I want to know what the 95% confidence interval is, there are lots of online calculators. You can plug those numbers in and they'll just spit them right out for you.
Gotcha. All right. Were the study patients similar to my patients? They were Europeans. They had good health care in general, so probably not. But to a certain extent, you know, maybe. Where's follow-up? Were all clinically important outcomes considered? So it seems like they generally were, because they did try to make controls for it and they did try to readjust their statistics to take into account things that they found later. But like I said, like without any, you know, without any way to kind of group people together or propensity scoring, it's kind of difficult to consider. It's limited. And are the likely treatment benefits worth the potential harm and costs? In this particular case, you know, even when we looked at the supplemental data, which is why I pulled that in, or decreased calls of AMI on there, when we, or decreased calls of acute coronary syndromes on there, when we looked at the potentials of doing less stress testing on people, and even though we had the same angiography, and the fact that in the long term, it seems that these high sensitivity troponins, because they increase throughput and then they typically save hospitals and patients money, it definitely seems like this is going to be a beneficial thing to have.
Excellent. Great analysis. Love the PowerPoint.
So it's all out of spite. It's all out of spite.
All right. Dr. Char, any last thoughts, comments?
So these are all good papers, slightly different focus of each one. I think the high sensitivity troponins are here. They're going to get rolled out in August. We'll do an in-service on it this Tuesday, as I mentioned, with more specifics about the assay itself and what we have to do, how it operationalizes at Barnes. But I think that the day of, you know, when I started as a resident, it was like STEMI, not STEMI. And then it was like STEMI ACS or something else. And now we're at a point where we don't just say, okay, they're not positive. We can actually now say they're truly negative. And that's changed with these new assays, and they're both reliable and they're reproducible and they're sensitive. And so as a result, I think it is going to hopefully change for many of us. We care for these patients, and hopefully we'll have a reduction in the amount of stress testing we do. And maybe that will translate into a reduction in the number of people that get admitted just for a rule out and stuff. And that would be nice if we could feel comfortable, because the uncertainty has been reduced to some degree with these new assays, with these pathways. And that's my hope, is that the individual uncertainty of a provider will be less now, and will be more willing to act on it and send people home, which is what we have not been willing to do up until now, if you look at our numbers.
Excellent. Anybody else? Any other thoughts, comments from anybody out there? Don't be shy. All right. Well, more to come as this gets rolled out. Thank you guys for joining in. Thank you, Doug, for helping to lead this discussion. I think this is an important topic as we roll out these new high sensitivity troponins and discuss how we are going to use them in conjunction, as you said, with some kind of clinical decision rule rather than just in isolation. I think that's important. So great job, everybody. As Julia said here, great job, everybody, except Nico. Mediocre at best. So no, great job, everybody. Thank you guys for joining us, and keep an eye out for emails about the next month's Journal Club. Thank you. Oh, one last thing before you go. I will be sending out a sign-in sheet to everybody. Just, you know, be honest, obviously, for those listening, you're here, so feel free to sign in. Let me know that you were present. So thank you, guys.